We're going to give this just another minute, and then we'll get started. Okay, welcome. My name is Rachel Bella Kramer, and I am the Opioid Settlement Coordinator with Chester County Department of Drug and Alcohol Services. I'd like to thank the Chester County Medical Society for providing this virtual venue for us to provide more information relating to substance use disorder. Today's lecture is the second in a series of 4 lectures, and they will be held every other Thursday evening through June 20th. Before I introduce tonight's speaker, I would like to let you know that we firmly believe that recovery is possible, and it is happening every day throughout our communities. I would also like to say that in Chester County, you don't have to take out a second mortgage to obtain substance use disorder rehabilitation services, as it is available to the uninsured and underinsured at no cost to the individual or their family. I encourage you to sign up for our newsletter and have posted links to our website and other resources available in the chat. If you have questions during this lecture, please place them in the chat and they will be answered during our Q&A session at the end of tonight's lecture. With that, I'd like to introduce Dr. Christoper Davis, our evening speaker. Let me just first provide a quick biography on him. Dr. Davis received his undergraduate degree in electrical engineering from the Pennsylvania State University and his Doctor of Osteopathic Medicine from Southeastern College of Osteopathic Medicine. His dual residency in internal medicine and pediatrics was completed at the Geisinger Medical Center in Danville, Pennsylvania in 1994, and he is board certified in internal medicine. Dr. Davis has developed and taught both an undergraduate and graduate level course on addiction and addiction counseling at Millersville University. Having started his practice in primary care, Dr. Davis branched out into treatment of substance use disorder. He has worked both as a clinician and a medical director in a variety of settings, to include an inpatient detoxification program and residential, methadone, and outpatient Suboxone clinics. Currently working in his private substance use disorder practice, he is a diplomate of the following: the American Board of Preventative Medicine, the American Board of Internal Medicine, and the American Board of Addiction Medicine. Please join me in welcoming Dr. Davis. Dr. Davis, I'm going to turn this on over to you.
Thank you very much, Rachel. Thank you for joining us tonight. Today's topic is medication-assisted treatment for opiate use disorder. So I wanted to start out by looking at just some demographics in the United States. So this first graph is looking at overdose deaths in the US from 1999 to 2021. And this is total drug overdose deaths. So it's not specific for any one. And if you can follow my cursor, 1999, and you can see a steady rise in all drug overdoses up to 2021, and becoming over 100,000 deaths. The yellow line is males, so we're having more males than females dying of drug overdoses. Now, since tonight's talk is medication-assisted treatment for opiate use disorder, what this graph is showing is overdose deaths involving all opioids. And what you can see is from 1999 to 2021, a steady rise in overdose deaths. And as of a couple years ago, 80,000 opioid-related overdose deaths. It's actually over 100,000 now. This data is a couple years old. And again, the yellow line being men, there's more male overdose deaths than females. Now, this graph is a little deceiving. What this is looking at is overdose deaths involving heroin. So it looks at overdose deaths due to just heroin and overdose deaths due to heroin plus some other opioid, which pretty much is fentanyl. So if you look at both combined, you see in the blue bar graph that total opioid overdose deaths involving heroin, so it'd be heroin and or heroin with or without fentanyl, it started to rise and peaked around 2016 and 2017, but then it started to come down. So you look at that, it's like, oh, well, that's probably good news. There's a decline in heroin and heroin plus fentanyl deaths. The blue line here is heroin alone, straight heroin. And again, it started to rise. And then around 2015, heroin deaths started to decline. It's like, well, that seems like good news too. And then the yellow line is heroin plus other opioids, which is pretty much fentanyl. You saw that begin to rise. And then around 2017, 18, it peaked and then started coming down. So this all looks like good information. So heroin deaths started to drop around 2015. Heroin plus fentanyl deaths started to drop around 2020. The two together started to drop around 2018. But it's misleading because when you look at what's on the streets now, it isn't heroin and it isn't heroin plus fentanyl. It's pure fentanyl. So that's not shown on the graph. So pure fentanyl overdose deaths is climbing very rapidly. So again, it's misleading that like we're making some progress in this opioid crisis, but in reality, we aren't. And what's on the street is straight fentanyl. You know, it has been probably 5 years since I've gotten a urine drug screen that was positive for only heroin. And rarely am I seeing a drug screen that's positive for heroin and fentanyl. It seems to be all fentanyl now. And the pandemic has not been good for this population. In fact, if you look at from September 2018 to August of 2019, so this was 12 months pre-pandemic, and you compare that to September 19 to August of 20, where the last 6 months of that time period was in the pandemic, there was a 27% rise in overdose deaths, mostly due to fentanyl. And although deaths from opioid overdose were already on the rise, this rise was faster than expected. And this graph sort of shows that. So the top line, the dark blue, is overdose deaths. And this would be of all drugs. And you can see right when the pandemic hit, all of a sudden it skyrocketed. It rose faster than you would expect it. And when you look at overdose deaths of opioids, the bottom one, the light blue, again, the pandemic hits and a rapid rise. Now, I'm not going to get into possible reasons why this happened when the pandemic came, such as social isolation, declining mental health, and so on. That could be a talk on its own. My point is when COVID hit, overdose deaths rose much more rapidly than we expected it to. Now, to understand some of the medications that we're going to talk about, we have to go a little bit into receptor theory. So I want to first talk about an opioid agonist. So an opioid agonist is a molecule that will bind to the mu opiate receptor and fully activate that receptor. So if you look down here, this is a cell, this is a mu opiate receptor, this is a full agonist, and it's actively turning that cell on. So when you activate a mu opioid receptor, what do you see? You see opioid properties. So you see analgesia, you see sedation, constipation, suppression of respirations, decrease in blood pressure, and eventually overdose. So what are examples of full opioid agonists? Well, heroin and fentanyl, the things that are on the street. Methadone is a full agonist, and remember that we'll be coming back to that when we talk about methadone maintenance. Oxycodone, hydrocodone, all agonists. Then there are partial opioid agonists. So these molecules, again, bind to that same mu opioid receptor, activate that same receptor, but it doesn't activate it nearly as intensely as a full agonist would. So the classic example of that is buprenorphine, which we will be talking about today, which is the active ingredient in the brand name Suboxone. And then there's opioid antagonists. So an opioid antagonist, again, binds that same mu opioid receptor, but it doesn't activate that receptor. So you can see the molecule here, and there's no activation of that cell. And so it binds that receptor, and it actually can reverse the effects of an opioid. So if there's already a full opioid in that receptor, and you give them an antagonist, if it's got strong enough receptor affinity, the antagonist will get into that receptor and pop out whatever agonist is there, but it will not activate that receptor. So classic examples of that is Narcan or naloxone, which we use as a rescue medication for overdose, and naltrexone, also an antagonist. The oral form used to go by the brand name Revia, and we'll be talking about the injectable form today, which is Vivitrol. And then you'll hear the terms receptor affinity, and that's basically how strongly that molecule will bind to that receptor. So drugs that have a high affinity are difficult to dislodge from that receptor, and they will pop out drugs with a lower receptor affinity. So let's look at some of our medication-assisted treatment options for opiate use disorder. So over here, there's oral naltrexone. Over here, there's oral methadone. We got Sublocade. We got sublingual buprenorphine products such as Suboxone. And we have Vivitrol, which is injectable sustained release naltrexone. So let's talk about methadone maintenance. I've always said methadone maintenance has kind of been the redheaded stepchild of addiction medicine. So it's a form of treatment that a lot of physicians don't know about and don't fully understand, and it's kind of its own little niche in addiction medicine. So methadone clinics have been around since the 1970s. The sort of the father of methadone maintenance for treatment of opiate use disorders is Dr. Dole. He started some of the first methadone programs in New York City. He did a lot of the preliminary research. We'll be looking at some of the studies that Dr. Dole did. Now, methadone, for the purpose of maintaining the opioid-dependent individual, can only be administered through a licensed methadone maintenance clinic. However, methadone can be prescribed by any physician that has a DEA number, but they cannot be prescribing the methadone for maintenance of opiate use disorder. They can prescribe it for pain or pain management, but not for the treatment of opiate use disorder. So what is methadone? So it's a full opioid agonist. So it stimulates that mu opioid receptor. And therefore, the more methadone you give as a full agonist, the greater the effect you'll see, whether the effect is elimination of opioid withdrawal or reduction in cravings for opioids, or all the other opioid effects, analgesia, sedation, respiratory depression, constipation, and so on. And it's kind of a unique molecule. Tolerance is slow to develop, so patients may remain on the same dose of methadone while on maintenance for many, many years and not require any dose adjustment. Methadone has a very strong receptor affinity, stronger than most other opioids, specifically heroin. So it binds into that mu opioid receptor and doesn't easily get displaced by the heroin. And this is exactly what we want when we're using it for maintenance therapy. We want that methadone in that receptor. We don't want any heroin to be able to get in that receptor. So essentially like blocking the effect of exogenous heroin use. Now, years ago, we used to arbitrarily define high and low dose methadone maintenance. So we would say low dose methadone maintenance was less than 80 milligrams, and this is back in the heroin days, and high dose methadone maintenance was greater than 80 milligrams. And years ago, when I first started doing methadone maintenance, I sort of had in my mind that, I'm going to keep everybody on a nice low dose. And so, I tried to keep the dose as low as possible. And what I found was the dropout rate from that program was higher than the national average. I probably was not being aggressive enough with the dosing. So if you look at low dose methadone maintenance, so under 80 milligrams per day, this may be a high enough dose to eliminate the patient's withdrawal, possibly. It may be a high enough dose to reduce their cravings, but if they used heroin while on it, they would feel the effect of heroin because you didn't have those receptors fully bound up with the methadone, so the heroin could get in and have an effect. At the high dose methadone maintenance, we call that a blocking effect. And so once you get up above 80 milligrams, what you begin to see is if the patient continues to use heroin, it doesn't seem to have any effect. And several studies, quite a few, showed that high dose methadone maintenance is more effective than low dose methadone maintenance, defining effectiveness as less positive urine drug tests for heroin and improve retention into a methadone program. So some old data here. This was back in 1988. So this would have been when heroin was heroin. And what this graph shows is escalating doses of methadone and the number of urines that are positive for heroin. So 100% of the urines would be positive, or only 60% of the urines would be positive, and so on. So what you see is as you escalate the dose of methadone, the urines tend to become more and more negative. And once you hit that 80 milligrams of methadone maintenance, the urine drug screens just basically become negative for heroin because the heroin doesn't work anymore. It's blocked. There's where that blocking dose of 80 comes from. Again, this is all in the heroin time. So there's definitely some proven benefits of methadone maintenance. So methadone maintenance has gotten a bad name, and we'll talk a little bit about that. But there's absolutely proven benefits of methadone maintenance. So one, reduction in heroin use. We just saw that in the graph. You get the dose to where it needs to be, and the heroin use stops. A reduction in mortality. You cut death rates in half in patients on methadone maintenance versus those who are in abstinence-based treatment. Reduction in crime rates and reduction in rearrest or arrest rates. Also, patients on methadone maintenance are less likely to acquire HIV and Hep C if they don't already have it. Why is that? Why are they less likely to get those two viral diseases? Well, if they get stable, they stop their intravenous use. If they stop their intravenous use, that means they're not sharing needles with other people and they're not acquiring these two infections. And also, methadone maintenance has been shown that in somebody who has HIV, it slows the progression to full-blown AIDS. Why? Methadone is not an antiviral medication, so why would it slow the progression? Well, it slows the progression because if you get the patient stable, they tend to be more compliant with their medical appointments. They tend to be more compliant with taking the antiviral therapy, so you are less likely to progress on to full-blown AIDS. And methadone maintenance also has definite proven benefits in the pregnant opioid-dependent female. So if a mom is actively using versus a mom on methadone maintenance, those on methadone maintenance have improved fetal outcomes. So the baby's birth weight is improved. They have less premature births. They have less miscarriages, less fetal demise. And if mom continues methadone maintenance after delivery, there's improved parenting, and therefore the baby is more likely to grow and reach its developmental milestones. So reduction in heroin use. So you saw that graph, how if you get that dose to the proper level, the heroin use stops. So if you look down here in the bottom, some literature published by Dr. Dole back in 1978. Methadone has been around so long. It's of all the medications used to treat addiction, this is the one that's been studied the most because it's been around for so long. So Dr. Dole did a study where he followed patients for an average of 72 months, so 4.5 years of follow-up. So if you looked at heroin use prior to going on methadone, so pre-treatment heroin use, 100% were using heroin. Well, not surprisingly, you're not coming into a methadone program unless you're actively using heroin. However, once they got into treatment, only 1% tested positive for heroin. So significant decrease in heroin use on methadone. Reduction in crime rate I had mentioned, and reduction in arrests. So in the same study for an average length of time of 72 months, 4.5 years, what they saw was patients entering into a methadone program, their pre-treatment arrest rates were 90 out of every 100 were being arrested every year. 90 out of 100 were being arrested yearly. However, once they got into the program, it fell to 5 out of 100 were being arrested every year. So there's certainly some big social impacts here. We're having a major impact on crime rates. And then there was a Sweden study that looked at mortality. And at the time of this study, which was in 1990, and this study followed patients for 5 to 8 years, the national average mortality rate in Sweden at that time was 10.2 deaths per 1,000 patients each year. And that's pretty average for a first world country. The US is about the same too. So 10.2 per 1,000 patients died every year. So they went out to this population, and these patients are what I would call the worst of the worst. So the most progressed of the opioid use disorder patients. So these were homeless IV heroin addicts. So they approached this large population and they offered methadone maintenance. And some went on methadone maintenance and others didn't choose to get into a methadone program, but allowed them to be followed during the time of the study. So we had 115 patients who were willing to be followed, but did not want to get into a methadone program. So what did they find? So that's your control group. That's untreated opioid addiction in the homeless IV heroin addicted population. So that's your control group, 115 patients. So what they found is when you followed those untreated patients, they had a mortality rate 63 times the national average for Sweden. 63 times. So if you take 63 times that national average, basically that means 643 people per 1,000 died each year. I mean, 2 years and you've wiped them all out. That's untreated addiction. Now, there was 166 who ended up choosing to go on methadone maintenance. And when you followed them on methadone maintenance, what you found was those who stayed in the program, their mortality rate dropped to only 8 times the national average, so 82 deaths per 1,000 patients each year. And the majority of those deaths were due to HIV/AIDS. Now, some of them entered this methadone program, but got involuntarily or administratively discharged for whatever reason. And what happened to them? Well, their mortality rate skyrocketed back up to 55 times the national average. So I guess the summary of this slide is patients do poorly not on methadone. They do very well on methadone. And if they get out of the methadone program, they do poorly, at least if they get out in an involuntary status. Now, there's some definite disadvantages with methadone maintenance. So one of them is a restrictive lifestyle. So patients have to come into the methadone program every day and dose every day. So, I mean, makes it kind of difficult to have an active life if every morning you have to go into the methadone program. Now, there are regulations about take-home doses. So after you've been in the program for a certain length of time and you have negative urine drug screens for illicit drugs for a certain length of time, you can begin to get take-homes, 2 take-homes for the week, and then 4 take-homes, and 5 and 6. And then when the pandemic hit, they really loosened the regulations. So we were able to give out much more take-homes than the patient may have actually qualified for, but it was at the judgment of the treating physician. So there were some patients that really did seem to be stable, but they hadn't been in the program long enough to get more than, say, 2 take-homes, but we gave them more. And what we found was, a lot of patients did pretty well. So after we got through that pandemic period of time, SAMHSA, who does a lot of the regulations for methadone programs, really loosened up on some of the regulations in terms of take-home doses. So coming back to a restrictive lifestyle, but it's becoming less restrictive than it used to be. The cost of methadone maintenance. So it used to be that only Medicaid would cover methadone maintenance. And in general, that's still true. Although some commercial plans have started to come around and will cover methadone maintenance. Some of the commercial plans might cover part of their treatment, like they'll cover their groups, they'll cover their individual therapy, they won't cover the actual methadone itself. So we have to sort of split out how we charge those services. So some of them could be billed to a commercial plan. So some commercial plans are paying for it, some are paying for some of it. Sometimes a methadone clinic can do sort of an ad hoc agreement with a insurance company for a specific patient to get it covered. If it's not covered and the patient doesn't have Medicaid, kind of the average cost is $120 a week. So that could be difficult for some patients, particularly the population that we're treating. Methadone maintenance doesn't prevent the simultaneous use of other illicit drugs. I mean, it's blocking the heroin, but it's not blocking cocaine and benzodiazepines and methamphetamine. And if a patient is on methadone maintenance and they want to come off of it, that's generally a very slow process. Patients can't tolerate rapid decreases in methadone dose. They'll start to have opioid withdrawal. So I usually tell patients, sort of depending on where their dose is, that it could take you a year to successfully get off methadone. Now, for those who've been in a methadone program and then taper off, what you find is their relapse rate ranges from, this is their 1-year relapse rate, 70% to 98%. So anywhere between 70% and 98% will relapse back to opioid use once out of the program. Now that's kind of a broad range and it looks terrible. And sometimes these numbers give methadone maintenance a bad name, that once you're on it, you're stuck on it forever. And it's a guaranteed relapse when you get out. But let's look at the numbers a little closer. So those who get administratively discharged from a program for some behavioral problem, violence, whatever, or they drop out of treatment against medical advice. These are the ones that 98% are going to have opioid use within the first year, usually immediately. Those who taper out successfully, 70% of them will relapse in the first year. Now that sounds terrible, 70%. But if you compare those numbers to residential treatment, inpatient drug and alcohol treatment, rehab, if you look at patients that go into rehab and then get discharged without any medication-assisted treatment, 70% are going to relapse within the first year. So what you're seeing is, regardless of the treatment, the relapse rates seem to be the same, because those relapse rates are not an indicator of the treatment, it's an indicator of the disease that you're treating. And we know that addiction is a chronic relapsing disease. Another problem with methadone maintenance is, how are they perceived by the recovering community? So patients might be trying to use Narcotics Anonymous as a support system. Many Narcotics Anonymous meetings look at somebody on methadone maintenance as they're not really clean. They can't get a 30-day or 60-day sobriety chip because they're still using. So there's a lot of stigma within the recovering community. Maybe if they're in Narcotics Anonymous, they want to get an NA sponsor. The sponsor might not work with them. Say, well, you're not clean because you're on methadone. I'm not going to work with you. And then another problem is those on methadone maintenance, being on methadone may preclude them from entrance into drug court programs or sober living facilities like recovery houses. Now, this is changing with time. I do remember having patients who were stable in a methadone program. They had very significant charges, and they got into a drug court program, which is very intensive treatment and monitoring. And but they were told they had to come off the methadone. And the probation officer was telling me that, they're to stay in this program, they have to come off methadone. So I would do the best I can to slowly taper them off of it. It was never as fast as the probation department wanted it to be. But remember, sometimes it takes like a year to get somebody successfully off methadone. And inevitably, you got bad results. The patient would crash and burn, relapse. But what we've seen in the past few years, because of the disaster of taking stable people off methadone maintenance, is that drug court programs are now much more open to medication-assisted treatment, including methadone programs. Some sober living facilities, some recovery houses are open to that as well. Although there can be problems with that. They could live in downtown and the methadone program might be outside of town. They're in a recovery house and they don't have a car, driver's license. How do they get from that recovery house every day to the methadone program? And it may take a month or more to stabilize a patient on methadone. So they come into the program and they're actively using, and you begin to dose them typically with 30 milligrams of methadone. Doesn't mean that their opiate use is going to stop at that point. You have to build their dose up. So it might take a month or two until you get some stability in that patient. And probation officers frequently don't understand that. So 3 weeks into the program, and they're giving a positive urine drug screen for an illicit opioid, and the probation officer is ready to throw them in jail, say, you're already on methadone and you're still using, this is a violation of, we're going to lock you up on a probation violation. So sometimes we do have to educate the probation officer. It's going to take a little time to get to that correct dose for them. And because methadone causes physiologic dependency, it's a full opioid agonist. You will have withdrawal if methadone is abruptly discontinued. So this can be a problem for somebody in a methadone program who gets incarcerated and immediately cut off the methadone. And I can tell you that withdrawal from methadone is terrible. Patients who have been on doses of 100, 120 milligrams of methadone and get incarcerated and cut off of the methadone, they are sick for 2 months. They have opiate withdrawal and significant insomnia and depression that just goes on and on and on. And maybe they're in for 3 months and they get released. They feel terrible. So what do they immediately do? They do what they know will make them feel better. They'll return to illicit opioid use, but because they've been incarcerated and haven't used an opioid in 3 months, their tolerance is reduced, and overdose deaths are very common upon release from prison. We're again seeing a change here in the past couple years, where prisons are now allowing patients who are already on methadone maintenance to continue on methadone maintenance. York County Prison, just within the past year, we've been able to work out an agreement with them so that they could continue on methadone if incarcerated. And the jail is literally 100 yards from the methadone program. So how do we start somebody on methadone maintenance? So they're coming into the clinic, they get admitted, they're actively using heroin, fentanyl, whatever. Well, the methadone can be dosed in somebody who's actively using an opioid, heroin or fentanyl. So they could have used fentanyl at 2 a.m. They come in that morning, we're admitting them at 8 a.m. We can dose them because methadone is a full opioid agonist. So you're not running into problems with precipitated withdrawal. And remember that, because when we talk about buprenorphine, it's a different story. So no risks of precipitated withdrawal with the induction of methadone. Untreated, as we've seen some of the data, untreated opioid addiction carries a very high mortality rate. And we also had mentioned that once somebody goes on methadone maintenance and gets stabilized, you cut their mortality rate in half. So methadone can be life-saving. However, there's a caveat to this. When a patient first comes into a methadone program, you are escalating their dose over that first month, sometimes 2 months. You're escalating their dose of methadone, trying to get them stable. However, they're continuing a lot of illicit drug use because they're not stable. So you actually see a rise in mortality in the first 30 days that somebody enters a methadone program compared to their pre-treatment mortality. So for that brief period of time, you're putting them at greater risk. But why do we do that? Because once we get them stabilized, there's a long-term benefit in reduction in mortality. That might seem a little strange, but there are other things we do in medicine that's similar to that. For instance, somebody's having multiple TIAs, you do a carotid ultrasound, you find they have a 90% blockage, you choose to do a carotid endarterectomy. There's a high stroke risk right after that carotid endarterectomy. However, if they don't have a stroke, you then have significantly reduced the future risk of a stroke by doing that procedure. So you're putting some increased risk up front for a long-term benefit. So to offset that increased mortality in that first month that somebody's in a methadone program, they really need to be in a methadone program for 1 to 2 years so that you get some of that long-term benefit in reduction in mortality. In other words, if somebody comes into a methadone program and they're putting themselves at that increased risk for those first 30 days, and they want to taper out in 4, 5, 6 months, then they didn't get any benefit. You increased their risk for a period of time, but they didn't benefit from the long-term benefit of methadone maintenance because they didn't stay on it long enough. So I try to always educate my patients. This isn't a quick fix. This is a maintenance program that you really need to be in for a couple of years or longer. So this graph shows, let's say average person has a mortality rate somewhere down here. Like, remember that Sweden study, 10.2 out of 1,000 people die per year. So somewhere down here. Well, when somebody's coming into a methadone program, they're an active opioid user, they certainly will have a much higher mortality rate than the general population. So they come into treatment, they got this mortality rate. You then enter them into the program and you start them on methadone, and those first 30 days, that mortality rate rises, and then they become more stable and their mortality rate drops. And then what happens is you reduce their mortality rate in half. So getting to a stable dose. So typically it'll take 1 to 2 months in the program to get to that stable dose, because you can only go up on the methadone dose so fast. It just becomes dangerous to escalate it by too much too fast. And there are regulations in terms of what dose you can start somebody on. So the initial dose is up to 30 milligrams. So somebody can come in, you could start them on 10, 20, 30. You cannot give them any higher than 30 milligrams. They can return back to, they could get 30 milligrams and return back to the clinic hours later, and you can give them a second dose of 10 milligrams. So 40 milligrams would be the maximum amount that you could give them in the first day. But you don't typically see that done where they get that additional 10 milligrams, because that's later in the day, and most of the methadone programs are only open in the morning. So we typically start them with a 30 milligram dose, and then we increase them by 10 milligrams every 3, 4, or 5 days with maybe an average dose of 120 milligrams. So you can see it's going to take time when you're going up by 10 milligrams every 3 to 5 days to get to that, say, 120 milligrams. It's different for everybody. But fentanyl's been a game changer. So we saw how heroin deaths fell and heroin plus fentanyl deaths fell because pure fentanyl hit the streets. And fentanyl has changed addiction medicine significantly. We'll talk about how it changed buprenorphine, and we're going to talk about how it changed methadone. So fentanyl is 50 to 100 times more potent than heroin, and death rates really climb rapidly once it hit the street. So those who survived fentanyl, survived long enough to make it into a methadone program, did so because they had the ability to form a high tolerance. So due to their high tolerance, higher doses of methadone are required to stabilize that person. And it appears that there may not actually be a true blocking dose of methadone for fentanyl. Fentanyl has a higher receptor affinity than heroin. So when we used to talk about a blocking dose of 80 milligrams, once you hit that point or higher, the person would not feel the effect of heroin if they used. That doesn't appear to be true with fentanyl. You can give a fentanyl addicted person enough methadone to get them out of withdrawal, enough methadone to reduce their cravings, but there may not be enough methadone to block the effect if they use. So does methadone maintenance even work now that we have the fentanyl crisis? And the answer appears to be yes. It appears to work, and it appears to still have that significant reduction in mortality. There was some literature published, Journal of Substance Abuse Treatment in 2020, and I think it was they were looking at patients in a methadone program or several methadone programs in Rhode Island. And so in this study, what they found was in these particular methadone programs at this time, the majority of patients were fentanyl users because that's what's out now, but treatment still proved to be life-saving. So even with fentanyl, you go on methadone, there's a reduction in opioid use, increased chances of getting the patient in remission, and improved retention in treatment. So methadone is working for fentanyl addiction. Now, I looked at some data from my clinic years ago, so 2014. So 2014, heroin was heroin. And I looked at the dose that everybody in that clinic was on. So, patients who were on 0 to 10 milligrams, there was one person. On 11 to 20 milligrams, there was one person, and so on. And you go up on the dose. And basically, it's a rough bell curve, which is what you typically see in a methadone program, a dosing curve. And as a bell curve, the peak seems to be in that 70 to 100 milligram range. So that seems to be like the average dose of methadone in the heroin era. And that's not surprising because remember, 80 milligrams was the blocking dose. And then years later, I gathered up some data again. So this is 2019. So this is when what was on the streets was pretty much heroin plus fentanyl, not pure fentanyl yet. And again, the dosing curve looks like a bell curve, but now the peak of the bell curve is in that 80 to 110 milligram range. So the curve's roughly the same, but it's shifted to the right. So the average dose is higher. Now, I didn't practice addiction medicine at the clinic differently in 2014 versus 2019, but that bell curve shifted. Why? Because what I found was more and more methadone was required to get the patient stable. Why was more methadone required to get them stable? Because fentanyl was out there and patients had a higher tolerance than they used to. So that's about all I'm going to speak in terms of methadone maintenance. So let's change gears to buprenorphine. So buprenorphine Comes in the old sublingual tablets, the Suboxone tablets. So this is a combo product with buprenorphine and naloxone, and the sublingual film, combined product. Zubsolv, again, a combined product of naloxone and buprenorphine. Subutex, which is pure buprenorphine. There's sustained release buprenorphine injection, Sublocade, and a newer kid on the block, the sustained release buprenorphine called Brixadi. So we'll talk about all these. So remember, buprenorphine is a partial opioid agonist. So it gets in that receptor, but it's not going to fully stimulate it like a full agonist. And therefore, it has a ceiling effect. Once you get to a certain dose, giving more isn't going to have any greater effect. Therefore, it tends to be less abused, meaning less overtaken. If somebody's on a pain medication like oxycodone, they can keep taking more and more and get the same effect. But if they're on buprenorphine, after a certain point, taking more isn't going to make a difference. So it's felt to be safer for self-administering. And as with methadone maintenance, buprenorphine maintenance cuts mortality rates in half. So this looks at opioid effect versus dose for a full agonist. So this could be methadone. So you can increase the methadone dose up and up and up and get more of an opioid effect. Eventually you cross a threshold where overdose and death occurs. Buprenorphine products has, you give them a higher and higher dose, it gets to a certain point and then it plateaus. Taking any more gives no additional effect. And then you got a full antagonist, naloxone. No matter how much you give them, there's no opioid effect. It's an antagonist. So how do we do a buprenorphine induction? Patient comes to the office, they're addicted to heroin, fentanyl. Well, previously, back in the old days, these inductions were done in the office under direct supervision. So back when heroin was heroin, somebody would come in the office, we would try to time it that they would have somewhere between 18 and 24 hours after their last heroin use, that they were in moderate opioid withdrawal, so at least a Cal score of 8. So 18 to 24 hours since last use, moderate opiate withdrawal. We would give them the first dose of buprenorphine in the office and monitor them and then send them home. But home inductions have been shown to be quite safe and are frequently done now. I haven't done an in-office induction of buprenorphine in probably a decade. One reason, you can't time it right. Like, how do you time it that they're coming in the office when they have enough abstinence that they're in moderate withdrawal and you can dose them right then? So I do the home inductions. I have regular communication with the patient, and they try to get absent for as long as they can. They review their withdrawal symptoms with me, and I tell them, I think you need to wait another few hours, or I think it's okay to go ahead and start dosing your buprenorphine. Get back to me in an hour. Let me know how you're doing. So there's a lot of correspondence with the patient at the time of induction, but they're at home when they're doing it. As I already mentioned, a patient back in the heroin days had to be in at least moderate withdrawal, Cal score above 8. You wanted them to have 18 to 24 hours. Usually that was pretty easily achievable. The patient could go a day without using. You would maybe prescribe some comfort meds for them to help them get that 24-hour period of abstinence. So maybe some clonidine, some gabapentin, some trazodone to help them sleep, maybe some Flexeril for the body aches. You get that 24 hours or moderate withdrawal, you dose them. Why does precipitated withdrawal even occur? So buprenorphine, remember, is only a partial agonist, meaning it only, when it gets in that mu opiate receptor, only partially stimulates that receptor. So if that receptor is occupied with a full agonist like heroin, and you give them buprenorphine with a high receptor affinity, it gets in there and it pops that heroin molecule out. So you go from full agonist activity to partial agonist activity, and that results in precipitated withdrawal. So if there was a recent heroin use and the receptors are fully occupied and fully stimulated, buprenorphine is going to pop that heroin molecule out. Again, fentanyl has been a game changer in the buprenorphine realm as well. So Patients that are using fentanyl and are coming into treatment, therefore they haven't died. Generally, what has protected them is they had the ability to form a high tolerance, and that kept them alive long enough to get into treatment. But there are some opioid dependent individuals with very high tolerances, and full doses of buprenorphine, Suboxone, may not be adequate to alleviate their withdrawal or to alleviate their drug cravings. There are some people that just can't stabilize on buprenorphine because it's a partial agonist. And in those situations, sometimes methadone maintenance is going to be their next option. Now, our understanding of fentanyl before the fentanyl crisis was just based on anesthesia literature. We knew that fentanyl was a very short-acting drug, that short half-life got out of your system very quickly. Urine drug screens became negative very quickly. But this was all based on single episode of fentanyl use. Our patients coming to us are not single episodes, they're chronic users. And so what happens is that fentanyl in the chronic user builds up in their adipose tissues, which we didn't know that before. And so they continue to test positive for fentanyl for a longer period of time than we thought they would. And because the fentanyl is in them for a longer period of time, you run a greater risk of precipitated withdrawal when you start buprenorphine. So somebody has used fentanyl, they're already in withdrawal within 4 hours. But if you start to buprenorphine at 24 hours, or sometimes at 36 hours, or even at 48 hours, you may see precipitated withdrawal. I've had patients that's been 72 hours, 3 days since their last fentanyl use, and they got started on buprenorphine and they had precipitated withdrawal. So it's not well understood why, but again, we believe it has to do with the chronic users and the storage in the adipose tissue. So due to the severe withdrawal coming off fentanyl, and patients are not able to start the buprenorphine for maybe 2 days, you could see how difficult it's becoming to do a buprenorphine induction. They can't get abstinent long enough to lower the risk of precipitated withdrawal. So what do? They come into you, they're an active user, they want to go on buprenorphine, they're a good candidate for buprenorphine, but they can't get abstinent for 2 days or 3 days. Well, you have several options. You can do inpatient referral and do an inpatient detox, and then once they finish inpatient detox, do the induction there, or once they get out. Or you can refer them to a methadone program. Or the newest trend is to do micro dosing of buprenorphine, and I'm not going to get too much into that today. But basically, if I could get somebody to get 24 hours of abstinence through comfort medications, and then I dose them with a 0.5 milligram of buprenorphine, and then an hour later give them 1 milligram of buprenorphine, and an hour later 2 milligrams, and then over a couple days escalate their buprenorphine dose until I get to the dose that's going to work for them. So very labor intensive, requires constant communications with the patients to do this. If they start to get precipitate withdrawal as you're going up, you have to back off a little bit. So this is the Suboxone combination product and the old Suboxone tablets. So when I say combination products, it has the active ingredient buprenorphine and a second ingredient, naloxone, Narcan, which is an antagonist. So buprenorphine is the active ingredient. It's a partial opioid agonist. It absorbs readily sublingually. This is the medication, this buprenorphine, that is what's causing precipitated withdrawal. It's not naloxone. It's the buprenorphine that's causing precipitated withdrawal. So if a patient comes to you and say, well, I'm afraid of precipitated withdrawal, so instead of putting me on Suboxone, can you put me on the mono product, Subutex? It's just pure buprenorphine. It doesn't make a difference because it's the buprenorphine that's precipitating the withdrawal. So what's the second product in there for? The naloxone. So it's an opioid antagonist. it's not absorbed very well sublingually. So when this medication is taken properly under the tongue, buprenorphine enters the system, naloxone minimally or doesn't enter the system. So why do they put it in there if it's not even being absorbed? The reason they put it in there is to deter intravenous use. Taking a buprenorphine film or buprenorphine naloxone tablet, grinding it up, dissolving in water, injecting. Because if they inject it intravenously, they will get the naloxone, and that will cause an instantaneous precipitate withdrawal. So patients knowing that they'll get instantaneous precipitate withdrawal through the IV use, it tends to defer the IV use. And remember, it's the buprenorphine now that's causing precipitate withdrawal when they're taking it sublingually. You do have the mono product of straight buprenorphine. You're going to have same potential problems of precipitate withdrawal. So it used to go by Subutex. I don't even think that brand's made anymore. Subutex in general is referred or reserved for pregnant women and those with either a documented allergy to naloxone or having side effects from naloxone. Most common one I see would be headaches. And so other than that two populations, I'm generally not using the mono product because it has a higher street value because it can be injected without the risk of the naloxone-induced precipitate withdrawal. So are there some potential advantages of Suboxone over methadone? Well, buprenorphine products can be prescribed by a physician, a nurse practitioner, a physician's assistant, as long as they have a DEA license. It used to be, when I first started doing this, you had to have a X waiver, it was called, a special DEA number to prescribe buprenorphine. That went away over a year ago. So if you have an active DEA license, you can prescribe it. You can prescribe it in 30-day supplies. It's a Schedule III drug, so you actually could put refills on it. So it may result, Suboxone may result in less of a lifestyle alteration. You go see your prescribing physician once a month, as opposed to going to the clinic every day or every week, depending on how many take-homes you have. The physician's visit for Suboxone might be, the cost of that might be covered by commercial insurances or Medicaid, and the medication itself might be covered as well. And there's less of a risk of overdose. You can overdose on methadone. It's a full agonist, but an average adult could probably swallow 20 Suboxone films and not have an overdose because of that ceiling effect. And depending on where you live in the state, Suboxone might be more readily available. If you look at a chart of where the methadone programs are in Pennsylvania, there's a lot over in the East Coast and the Philly area, where I'm at, York. There's a lot over in the West Coast in the Pittsburgh area, but there's a lack of programs in the middle of the state. They're just next to none there. So if you live in the middle of the state, methadone might not be available, but there might be a physician that prescribes buprenorphine. Another potential advantage of Suboxone over methadone would be in pregnant women. There is a lower risk of neonatal abstinence syndrome, meaning the baby having withdrawal, lower risk of neonatal abstinence syndrome if the mother has been maintained on buprenorphine compared to methadone. And again, in pregnant women, we're usually using the monotherapy. So the risk of neonatal abstinence syndrome in a mom on methadone is about half those babies will have withdrawal. And if they've been maintained on buprenorphine, somewhere between 20 and 25% will have withdrawal. Suboxone has a high street value and there's a high risk of diversion. I have had quite a few patients that have come to me stable on buprenorphine, but never got a prescription. So for the past 3 years, they have been off illicit opioids and using Suboxone, but never got a prescription. They were getting it off the streets and they wanted to get legitimate. They were concerned about the getting arrested for illicit Suboxone use. So they come to me, and They're actually very easy patients to treat because they're already on it. So you don't have to worry about the induction period and precipitating withdrawal. And, if their urine drug screen up front is only positive for buprenorphine, it lines up with their story. So they come to me stable, just wanting to get legitimate. There's less a potential problem of Suboxone is there's less monitoring and accountability compared to a methadone program. When you're entering a methadone program, you're coming in every single day. So somebody's laying eyes on you every day. Maybe the dosing nurse, it might be the counselor. Buprenorphine does cause physiologic dependency. And again, that can be like with methadone, a problem during periods of incarceration. They get cut off, they go through withdrawal, they feel terrible for a period of time, they get out of jail, relapse, tolerance is down, they overdose. Although that trend is changing where patients on buprenorphine maintenance going into jail, some of them are able to maintain on buprenorphine in jail. You may frequently see benzodiazepine abuse in patients on buprenorphine. And as with methadone, it may preclude them from entering drug court programs and sober living. Again, that has changed, and drug court programs are much more receptive to buprenorphine maintenance. I want to review this study called the Prescription Opioid Addiction Treatment Study, POETS, which went from 2006 to 2009. So this study was designed to see if short-term buprenorphine and tapering off was as effective as long-term maintenance, and whether the addition of counseling had any improvement in outcomes. So there were 653 patients in this study, and they all had prescription opioid dependency. So these were not patients that were using illicit heroin or fentanyl, prescription medications. So they entered this program. They get divided into two groups. So the first group, group one, got 2 weeks of stabilization on buprenorphine and then a 2-week taper. And then they looked at them 8 weeks after that. Half of them got counseling, half of them didn't. So stable 2 weeks, taper off 2 weeks, look at them 8 weeks later. Group two, 12 weeks of maintenance or 12 weeks of stabilization on buprenorphine, a slower 4-week taper, then look at them 8 weeks later. Half got counseling, half didn't. Every patient had a weekly 15-minute appointment with the physician, and counseling was twice a week for the first 4 weeks, and then it dropped to weekly for the remaining time. So what did they find? So group one, who was on it for 2 weeks, tapered off in 2 weeks. 8 weeks later, only 7% were abstinent once they completed that taper. So basically, they all relapsed once they tapered out. Group two, who had that 3 months of stabilization, then taper slower, during that 3 months of maintenance, almost 50% were abstinent, but then they tapered off. And 8 weeks after they tapered off, only 9% were abstinent. So again, essentially all relapsed once they came off. The addition of counseling to either group had no difference in their outcome. So kind of the conclusion is patients do well on maintenance and do poorly when taken off. Some physicians look at buprenorphine as sort of a brief treatment. So, we'll put you on it for a year or two, but then you got to get off of it. You got to get off of it. But we don't necessarily do that for patients with other chronic diseases that are being managed well. I've never put somebody on an antihypertensive and 2 years of good blood pressure control and then say, okay, your blood pressure has been really good for 2 years, so it's just time to get off this. Or the diabetic who's well controlled on oral agents. It's like, okay, you've had great sugars for 2 years. It's time you get off of it. So we have to look at addiction as a chronic disease like many other chronic diseases. And there are going to be some people that are going to be on maintenance therapy a long time or all their life. There are others that may be well motivated and want to get off, and it can be done, but it has to be done cautiously. So this just shows the kind of a graph of the two groups. Group 1, 2 weeks of buprenorphine, 2-week taper, almost all relapsed 8 weeks later. Group 2, 3 months of stability on buprenorphine, about half stopped using, taper them off. 8 weeks later, they pretty much all relapsed. So why didn't the counseling have any impact in either of these two groups in this POET study? Well, perhaps the counseling wasn't intense enough to have an effect. I mean, they did get counseling twice a week for the first month. Or perhaps the counseling didn't add anything more because the patients were already seeing a physician every week for 15 minutes. So they had some kind of encounter with somebody who had a concern for their well-being. And maybe because of that, the counseling didn't add much, but maybe if they only saw the physician once a month, that counseling might have added more. Or perhaps it was the population being treated in this study. So remember, this was prescription opioid users. This was not IV heroin users. So perhaps this population, they were less progressed in their addiction. They had less instability in their lives where the counseling may have had a big impact on. But we don't know. So let's move on to Sublocade, which is our first extended release buprenorphine product that came on the market. This is just showing how you give the injection. Sublocade is given subcutaneously, and it can only be given in the abdomen. You rotate around, so right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant, and you just rotate around. So Sublocade is an injectable extended release form of buprenorphine. It got FDA approval in 2017, so it's not a brand new medication. To use Sublocade, the patient has to be stable at least 7 days on sublingual buprenorphine before starting Sublocade. So some of my patients maybe have been on sublingual Suboxone for years, and they just want to transition over to Sublocade. Or perhaps somebody's coming to me unstable, actively using, and maybe a challenging process to get that Suboxone induction done, particularly in the era of fentanyl. But once I get that induction done, I have to have them stable for a week on the Suboxone, then I can proceed with Sublocade. And the dose is pretty much the same for everybody. It doesn't matter what dose of Suboxone they were on that got them stable. The Sublocade dose is the same for everybody. Month 1, they get 300 milligrams. Month 2, they get 300 milligrams. And then month 3, it drops down to the maintenance dose of 100 milligrams. And for most people, they stay at 100 milligrams every month. However, if after their first 100 milligram dose, the patient is reporting breakthrough withdrawal, you can go back up to 300 milligrams and stay at 300 milligrams as a maintenance. I think I have one person that's on 300 milligrams of maintenance. Everybody else did the 300, and down to 100. So why is the dose the same for everybody, regardless of what Suboxone dose they previously got stable on? Well, this medication was designed, this 300, 100, that regimen was designed to achieve a steady state plasma level buprenorphine somewhere around 2 to 3 nanograms per milliliter, which appears to result in about 92% mu opiate receptor occupancy. So when they designed this, they didn't look at, okay, this was how much Suboxone they're on, so this is how much Sublocade they're on. They're looking at this much Sublocade gets their plasma levels to a point where you can get nearly full occupancy of the mu opiate receptors. Now, it's not uncommon when that patient gets that first 300 milligram dose and they come back to you in a month for the second 300 milligram dose, that they started to have some mild breakthrough withdrawal towards the end, maybe the last 5 to 7 days. However, I assure them that when they get that second loading dose, that those symptoms almost always disappear. So the first month could be a little tough for them. So what are some nice advantages of Sublocade as an extended release form of buprenorphine? Well, it can be given to somebody prior to release from rehab. so that gives them a month then to engage with a outpatient provider. There's certainly no risk of diversion with the injection. There's no risk of misuse or overuse of the medication. And if somebody's on Suboxone maintenance and is going to be incarcerated for a brief period of time, I always worry that they get incarcerated on Suboxone and it gets cut off, although there's some improvement in that area, but they get cuts off and they get very sick from withdrawal. Where if I can give them a Sublocade dose, I can carry them for a month, and it may somewhat auto taper because it's not like at a month it drops. It slowly the levels slowly drop, and after several injections, it may last for 5, 6, 7 weeks. So if a patient's on Suboxone and they miss their appointment with me, they are in panic because I might not be able to get them in tomorrow or the next day, and they're going to run out of their medication. But if they're on Sublocade and they get stuck out of town at work, or they just forget their appointment and they get back to me, it's like, I missed my appointment. It's like, okay, I'll see you early next week. They're going to be fine. Patients can pretty much easily go 5 weeks. I've had one guy, he could go 9 weeks between injections without starting to get a little bit of rhinorrhea. Some disadvantages Sublocade. If the Sublocade is being administered in an outpatient treatment program where they're getting their counseling and they're getting their injection, they could get that 1 month injection and then just disappear and not follow through with any of their drug testing, not follow through with any of their counseling. And how do you take somebody off Sublocade? That question's never really been answered. But if somebody's been on and say, it's time, I'm really thinking about getting off maintenance therapy. And there's some reported cases where people just stopped it and it just seemed to auto taper, and they claim they never had any withdrawal. Although that's not generally what I see. I do find at some point they begin to have withdrawal symptoms, but there are reported cases, some that don't. So how do you get them off of it? Do you give them smaller doses? That would be off-label use because it's only recommended the 300 to 100. Do you spread out time between the injections? There's still a lot to learn in terms of that. And then after discontinuing Sublocade, buprenorphine can be detected in their urine for 9 to 12 months later. And sometimes probation officers need to know that because they may have been on Sublocade and they stopped it and it's 9 months and their probation officers drug testing them and they're positive for buprenorphine and they're convinced that that person's still using, but it's still residual buprenorphine in them. And because it's in them for so long, it may mean that Vivitrol is not going to be a good treatment option for them later, because Vivitrol is an antagonist. You give it to them and there's still a lot of bup in them, they'll have precipitate withdrawal. And then the new kid on the block is Brixadi, which is another form of a sustained release buprenorphine product. There's a weekly injection and there's a monthly injection. So Brixadi comes as a weekly and monthly subcutaneous injection, and you actually have more injection site options. You can do the abdomen like with Sublocade, but you can do the upper outer arm, you can do the thigh, you can do the buttocks as well. And there's 3 different monthly doses that are available, 4 different weekly doses that are available. So you pick the dose based on what dose of Suboxone they were on and got stable on. So if somebody was stable on less than 6 milligrams of sublingual buprenorphine, you would use an 8 milligram dose of weekly Brixadi, but there is no recommended dose for the monthly. So, and I don't think patients are going to want to get a weekly shot forever. At some point, they would want to go to a monthly. So what do? Well, you could build their Suboxone dose up a little and then move over to the next dose of Brixadi. So if they're on 6 to 10 milligrams of sublingual Suboxone, they would get 16 milligrams of the weekly injection or 64 milligrams of the monthly, and then higher doses of sublingual buprenorphine, higher doses of weekly or monthly Brixadi, all the way up to 24 milligrams. That'd be 3 8 milligram strips. If If you put them on a monthly injection, it's 128 milligrams of Brixadi. Honestly, I've never used a weekly product. I get them stable on sublingual buprenorphine, and I just go right to the monthly product. But maybe some patients are a little afraid to do that, and they want a test run, and they're going to want some weekly injections. But I haven't found a need to use it. What if you get an opioid naive patient, somebody who has a history of opioid dependency? They're not currently using, maybe they've been in jail for 30 days, and they are very fearful that when they get out of jail and return to that same environment with all those environmental cues, the people, places, and things, that their drug cravings are going to rise, which is not uncommon, and they're going to relapse back to illicit opioid use. So they're coming to you with no opioids in their system, but they want to go on buprenorphine maintenance because they fear a relapse. And they want to go on Brixadi. So how do you do it? Well, you first give them a test dose of 4 milligrams of sublingual buprenorphine. And that's basically to make sure you don't get precipitated withdrawal. Hopefully you won't, because they've been abstinent in jail, and you're going to get a urine drug screen as well. Then an hour later, you give them a 16 milligram weekly Brixadi injection. You have the option 3 days later to give them another 8 milligram dose of weekly Brixadi. So it's not required, but optional. And then when you're a week out from the first injection, you then increase them to the 16 milligram buprenorphine weekly injection. After that, you can then convert to 16 to the monthly injection, which is 64. So if go back to that previous slide, they've been getting the 16 milligram weekly injection, and it's time to switch them to monthly. You move them over here to the 64. Okay. So there might be some advantages of Brixadi that I see over Sublocade, and I also see an advantage of Sublocade too. So Brixadi has more injection site options, so it doesn't have to go in the abdomen. You got 4 different areas you can go, and there is more dosing flexibility. So if somebody's on pretty low doses of buprenorphine, and I give them 300 milligrams of Sublocade, I sort of feel like I'm moving backwards. Like, they're trying to get off of it, and they're on a low dose. And now I'm, giving them 300 milligrams of Sublocade. I feel like it's a step in the wrong direction. But Brixadi has those other dosing options. There's, for the monthly injection, remember, 3 dosing options. Brixadi is definitely less painful. When I put a Sublocade injection in somebody's abdomen, they're always like, oh my God, it's burning so bad. Now, it only lasts for about 30 seconds, and then it just, as quick as it came, it just kind of stops, but it does burn. And now that it's summertime, I can tell you that bikini season, women don't want a large Sublocade bulge in their abdomen. And those first 2 doses of 300 milligrams, they do leave a big lump there. When you discontinue Brixadi, it does remain detectable in the urine for quite a long time, but not as long as Sublocade. Now, I don't think that's good or bad, but so I guess if the Brixadi comes out of the urine quicker, then maybe you have less likely to have problems with their probation officers drug testing them. But if I have somebody that is going to go off to jail, and I don't think that they're going to get any MAT there, I'm more likely to use Sublocade because it seems to last longer, it seems to stick around longer. So I sort of feel, and I don't have any evidence, but I sort of feel it'll taper them slower than Brixadi. And then we move on to, just check how we're doing on time here. We're good. Okay. And then we move on to naltrexone, Vivitrol. Now, I'm not going to talk about oral naltrexone, used to be Revia was its name. I'm not going to talk about oral naltrexone for the treatment of opioid dependency, even though it has FDA approval. Why aren't I going to talk about it? Well, the bottom line is it doesn't work. Old literature looking at people with heroin addiction, you put them on oral naltrexone, compliance is horrible. They all stop taking it. They all relapse. It just doesn't work. Now, it's different for Alcohol, oral naltrexone plays a role in alcohol. We'll talk about that in my next talk. But for the treatment of opioid dependency, oral naltrexone just isn't going to cut it. And at that time, when studies were coming out that shows that it's very ineffective, some of the studies say, it would be nice if there was some kind of sustained release form of naltrexone. And basically, that's what Vivitrol is. So Vivitrol got FDA approval for opiate dependency in 2010. It had already been on the market for the alcohol indication as of 2006. So this is not a new medication. So how's it work? Well, if we look at this first picture here, that's a cell membrane. These are mu opiate receptors. And the whole reason we even have mu opioid receptors is because we have our own natural endorphins, our own natural opioids that bind to those mu opiate receptors and activate it. However, we can take exogenous opioids such as heroin, fentanyl, oxycodone, hydrocodone. So those full agonists, like heroin, would bind that same mu opiate receptor and again activate it. Vivitrol, which is extended release naltrexone, is an opioid antagonist. So it binds that same mu opiate receptor, but it does not activate it. And it has a high receptor affinity, which means if there's exogenous opioid use, that opioid can't easily get into that receptor. So for an antagonist, a blocker, we want something that has a high receptor affinity. So how well does Vivitrol work and what has it been shown to do? So Vivitrol improves complete abstinence rates compared to placebo. Vivitrol reduces the number of relapses that patients have. And in those who do relapse, it prevents them from falling back into physiologic dependency, where maybe they have to go through detox again. Vivitrol reduces cravings for opiates. Now, this is not well known, but in head-to-head studies of Vivitrol versus Suboxone, looking at cravings, Vivitrol was not inferior to Suboxone in reduction of cravings. So patients might think that Vivitrol is just going to block them, so if they use, they can't get high. But it does more than that. It helps with those drug thoughts and cravings. And Vivitrol improves retention rates for patients that are in outpatient drug and alcohol treatment, meaning they're less likely to drop out of treatment. So the pivotal study that got Vivitrol FDA approval for the treatment of opiate dependency was actually conducted in Russia, and it was published in the British journal Lancet in 2011. So this was a double-blind, randomized, placebo-controlled outpatient trial where 126 patients received Vivitrol for 6 months and every other week counseling, or a placebo injection every month and every other week counseling. And they were followed for that 6-month period of time. It was blinded, so the patients didn't know whether they were getting the placebo injection with counseling or the Vivitrol. Prior to entrance into the study, a lot of these patients did require detoxification. They're actively using opioids. You can't start them on Vivitrol, you'll precipitate withdrawal. So a lot of them required detox and residential treatment first. And the average length of time in residential treatment for the patients in this study was about 18 days. So this looks at the study results when looking at complete abstinence rates. And this data was from injection number 2 to the end of that 6-month period of time. They didn't look at the data for the first 30 days. They looked at that as a stabilization period. So they get their first injection. Once they get injection number 2, now they start to gather the data out to 6 months. So what they found was for those who received Vivitrol and counseling, 36% of them had complete abstinence from that second shot out to the end of the study. So about a third had no opioid use. Those who got the placebo, less than a quarter, 23% had no opiate use. So complete abstinence rates were definitely improved with the Vivitrol. But we know that patients in early recovery may struggle and they may have some relapses. They may have some uses. It's a chronic relapsing disease. It may take time to get to that goal of complete abstinence. So what else they looked at in this study was opiate-free weeks. So in this 6-month study, how many of those weeks was there no opioid use? And if they received Vivitrol with counseling, 90% of the weeks there was no opioid use. If they were receiving the placebo injection, 35% of the weeks there was no opioid use, which actually means they used more weeks than they didn't if they were on placebo. This looks at cravings. Remember, I said Vivitrol does more than just block use and prevent you from falling back to physiologic dependency, but it reduces cravings and is shown to not be inferior to Suboxone in reducing cravings. So the top gray line is a craving scale. Every week somebody did this visual analog scale and they would measure their cravings. So they get out of rehab, they come in this outpatient study, they are getting the placebo injection. Initially, there's a spike in their cravings, comes down, and then just over the 6 months of the study, there just really isn't any improvement in their cravings. In fact, at the end of 6 months, their craving score was slightly higher than when they entered the study. So why was there this spike, the first couple of weeks into the study where they really start craving? Well, we don't know for sure, but here's my theory. They've been contained in residential treatment. They get out. They're now into that home environment, people, places, and things. So all of a sudden, they're bombarded with all these environmental triggers that they've been away from for a while. So that may have heightened their cravings for a brief period of time, comes back down, but it just doesn't get better. Those who got Vivitrol, and you looked at their weekly craving scale, just a continued drop in their cravings that was then maintained during the 6 months of the study. In fact, they get their first shot and there's a reduction in cravings. They get their second shot, there's further reduction. They get their third shot and there's further reduction. So if I have a patient with opiate use disorder that I give them their first shot, and when they come back in 4 weeks, they might say, doc, the last 5 days have been really tough for me. I'm really craving. What I can tell them is you'll have further reduction of those cravings with shot 2 and even further with shot 3. Something that is not uncommonly done is patients may be on Vivitrol given a prescription for oral naltrexone too, and just told, just keep it there. And this would be off-label use, but if they got their first injection and they're 5 days before their next injection, they're really struggling, they might want to supplement with oral naltrexone. The other advantage of having them have some oral naltrexone is, what if they miss their second or third or 8th injection? What if they miss that appointment and they can't get in for the following week? I just say, well, just start taking your oral naltrexone until you come back in for your next injection. Another thing this study showed, so besides improved complete abstinence rates, improved opioid-free weeks, improved reduction in cravings, also retention and treatment was improved. So those who received counseling with Vivitrol in the 6-month study, the median patient had 168 days in treatment. That is 6 months. The median patient in the placebo group was 96 days, which means more patients in the placebo group dropped out of treatment. So we saw with methadone and buprenorphine that it cut mortality rates in half. And so has it been well established that, it has been well established that both methadone and buprenorphine is life-saving, reduction in mortality. But what about Vivitrol? Does Vivitrol improve mortality rate in the opioid-dependent population? Well, it's difficult to answer that question. So if you want to do a study to see if a certain medication compared to placebo, if a certain medication reduces relapse rates, it's not that difficult to do because relapses are so common. So you can have a study where you have just a small number of patients and just follow them for a short period of time. And because relapse rates are so high, in that small population for a short period of time, you're going to probably see whether that medication is reducing relapse rates. But what if you want to do a study looking at mortality? Well, since the majority of people relapse don't die, fortunately, the majority that relapse don't die. If you want to see a medication's impact on mortality, you need large number of patients in a study and follow them for a longer period of time so you can tease out whether it's statistically significant an improvement in mortality rate. The only study so far that I've ever been able to come across that maybe suggests that Vivitrol reduces mortality was published in the New England Journal of Medicine, March of 2016. So as part of a reentry program, meaning people who are in prison and they're being released, as part of a reentry program, there were 300 inmates who were assigned to either get a Vivitrol injection every month for 6 months, or what the article called treatment as usual. So what's treatment as usual? Well, when you sort of look more and more into that, kind of dissect it out of the article, it basically was case management. So 6 months of Vivitrol, 6 months of case management, but then follow them for 18 months. And what they found is at 18 months, those who received Vivitrol for the first 6 months, at 18 months, there was no deaths. Those who got treatment as usual for 6 months, at 18 months, there were 7 overdose deaths. So it sort of suggests that Vivitrol might reduce mortality. Again, small study, not a long period of time, but it sort of suggests that. So it's very easy to start Vivitrol in the inpatient setting. So the patient goes in, they go through detoxification, you wait 7 to 10 days, and then you give them their first Vivitrol injection. You wait that 7 to 10 days after detox so that you avoid precipitated withdrawal when they get Vivitrol. But initiating Vivitrol in the outpatient setting in somebody who's actively using opioids is very challenging. And it's one of the more difficult things I do in my office. So I have somebody coming to me, they're actively using fentanyl, injecting fentanyl. How am I, and they want to get on Vivitrol. How do I do that? Well, I could refer them to inpatient detox and rehab and either let them give the first injection there, or as soon as they get out, come in the office and I'll give them the first injection. That's one way. But a lot of patients are going to be very reluctant and resistant to go into residential treatment. Another technique is ambulatory detox. So I put them on a 7-day taper of Suboxone and maybe some comfort meds, but then I got to wait 7 more days for the Suboxone to clear out so they don't get precipitated withdrawal with the Vivitrol. So 7-day detox, 7 days of abstinence, give them Vivitrol. Success rate isn't great. Using that technique, only about 32% will maintain their abstinence during those last 7 days to be able to get Vivitrol. So there are some newer techniques out there. Again, I'm not going to go into any specifics on them, but some of them techniques that I use. And one of them is micro dosing with oral naltrexone. So they're actively using, or they got a day of abstinence, and you give them a very small dose, milligram of oral naltrexone, and then you build them up the next day, 2 milligrams of oral naltrexone, 5 milligrams, and you build them up over a week or two as they tolerate it. You keep going up as they tolerate it. And I tell them, if you use, don't stop the naltrexone, just keep building up on the dose, and don't worry about the use, keep building. And if I can get them up to 25 milligrams of oral naltrexone and they haven't had any precipitated withdrawal, they're going to be safe to get the Vivitrol. So can somebody on Vivitrol overdose on opioids? And, Vivitrol is not increasing the likelihood of an overdose. It's not making it more likely to happen. It's protective. It's probably reducing the risk of an overdose, getting back that mortality data. But that being said, people could overdose on Vivitrol. So how would that happen? Well, the two most likely scenarios. let's say somebody got a Vivitrol injection 2 weeks ago. They're blocked. And then they have a relapse. They inject a bag of fentanyl. Nothing happens. Like, wow, I was blocked. What do I do now? I'll inject 5 bags of fentanyl. Wow, nothing happened. I inject 37 bags of fentanyl. There's some level of opioid use, particularly if administered rapidly through the intravenous route, that may override the blockade of the Vivitrol. If they override the blockade, doesn't guarantee it's going to be an overdose, but it certainly means they're now at risk, that the protection is no longer there. So you have to have that discussion with patients, not to try to intentionally override the blockade, because it could be fatal. The second scenario, let's say somebody got a Vivitrol injection 25 days ago, and I'm giving it every, say, 28 days. So the longer a patient has been abstinent from opioids, the less their tolerance is. And it doesn't matter how they got abstinent. Maybe they're abstinent because they've been on Vivitrol for 6 months, or they've been in jail for 9 months, or they've been in rehab for 30 or 90 days. Abstinence results in reduction in tolerance. Now, if their last Vivitrol injection was 25 days ago, their blockade is wearing off. There's less naltrexone in their system. So you could have somebody who then uses as much opioids as they previously have, and their blockade is wearing off, and their tolerance is reduced. And in theory, you could see an opioid overdose at that time. Or worse yet, they actually skip their next injection, and at day 35 they use. Well, at that point, there's no longer any protection from the Vivitrol. It's gone, and their tolerance is down, and they potentially have an overdose. Can somebody take Vivitrol if they're pregnant? Well, in general, I say no. There's very limited safety data during pregnancy. There's very limited safety data during breastfeeding as well. There's some safety data available for oral naltrexone, and you could extrapolate that to Vivitrol, but specifically Vivitrol, just not enough data to do it. So when can you start somebody on Vivitrol? Well, a person has to be 7 to 10 days off opioids to get the first injection to reduce the risk of precipitated withdrawal, which means if they're in residential detox, they have to be 7 to 10 days after they've completed detox, because what did they use to detox them? Probably either buprenorphine or methadone. If the patient has been on long-term buprenorphine Suboxone maintenance or methadone maintenance, you want them to be 14 days off those medications before starting Vivitrol. A methadone to Vivitrol conversion is extremely difficult to do. And I've only ever actually did it one time successfully. The reason it's hard to do is, first of all, if they're on methadone, you got to get their methadone dose way down and then taper them off. And then you got to wait those 14 days and hope that they don't relapse while you're bringing their methadone dose down, and hope that they don't relapse during those 10 to 14 days before they get the first Vivitrol shot. So it's very difficult to do it. I'll share one example, though, where the one case that I was able to do it. It's kind of a funny story, too. Girl named Brooke, she was in a methadone program, and she was up to 100 milligrams of methadone, and she was still actively using fentanyl. And now, Brooke, I had treated many times in the past in different treatment settings. And I had treated her in the past in my office a couple times on Suboxone. She never really did well. I had treated her in the past in my office on Vivitrol, and she did quite well. But at some point, she discontinued her Vivitrol, and then some point after that, she relapsed. So she's in the methadone program now. She's on 100 milligrams of methadone. She's still actively using, and she's telling me, I want to go on Vivitrol. It was the only thing in my whole history that I really had a good outcome. I'm like, Brooke, how are we going to do that? Like, you're on 100 milligrams of methadone, you're still using, you haven't even got stable. Like, if I taper you off the methadone, like, your use is just going to escalate. And then the next thing you know, you're just going to be using. And then how are you ever going to get on Vivitrol? So she's like, just taper me out and I'll call you. I'm like, I don't recommend this, but that's what she insisted. So we kind of rapidly tapered her off the methadone. She left the program. And sure enough, about 3 weeks later, she calls me up. She goes, I'm ready to come in the office to get my Vivitrol injection. I'm like, are you kidding me? Like, are you telling me that you have tapered off the methadone and have had no opioid use? She goes, that's right. I'm like, how did you do that? She said, I smoked a hell of a lot of pot. So whatever worked for her, but she came in and gave me a negative urine drug screen and she got started on Vivitrol. And that was my only successful methadone to Vivitrol conversion. So can somebody take Vivitrol if they're on psychiatric medicine? Yeah. So Vivitrol doesn't interfere with antidepressants, doesn't interfere with anti-anxiety medicines or mood stabilizers or antipsychotic medications. Now, I will say this, naltrexone, whether it's oral or injectable Vivitrol, naltrexone in itself can cause depression. So it's not common, but that is one of the known side effects of Vivitrol. So I do talk to my patients and their family that when you go on Vivitrol, if you see a change in their affect, I'd like to bring them back in and reassess them. So let's see, are we doing on time? Yeah, doing well. So summary slide. So opioid overdose deaths have been on the rise for the past 2 decades. And around 2015, heroin overdose deaths began to decline, but heroin plus fentanyl overdose deaths rose. Around 2020, heroin plus fentanyl overdoses declined because now it's pure fentanyl that's on the street. The current FDA-approved medications for opiate use disorder, methadone, which remember has to be done through a methadone maintenance program, a license program. You got buprenorphine. We talked about the sublingual preparations, but there's also the sustained release Sublocade and Brixolti. There's oral naltrexone, which we didn't go into because of its ineffectiveness in opioid use disorder. Vivitrol, which is sustained release naltrexone. We've seen that both methadone and buprenorphine cut mortality rates in half. That Vivitrol probably reduces mortality, but limited data. And then this last slide is some pictures, astrophotography stuff I've done with my telescope. So in the top left here, that's called the Orion Nebula. And in the lower right, that's obviously the moon. So with that, I will turn it over to you, Rachel.
Terrific. Thank you so much for a wonderful presentation, Dr. Davis. I would like to now open it up to questions. If anyone has a question, if you could type it into the chat and I will read them off to Dr. Davis. Anyone have any kind of questions they'd like to ask? Janet, are you receiving any questions on your end? You know, sometimes they don't come to me.
No, it all looks great. It was a great presentation.
Terrific. Well, if no one has any questions, then I will just simply announce that we have another wonderful lecture with Dr. Davis.
Hold on, guys. What about semaglutide, another GLP-1 agonist that might be helpful in this area as well as adjunct therapy?
I have no experience in using that medication, those medications. Maybe you can share whatever you've learned about them.
Just what I've read, that they might be helpful for multiple substance use disorder issues to reduce cravings in a significant amount. So it might be a good adjunctive
therapy.
Yeah, in somebody who has trouble or is not successful with current therapy.
Right.
And has other comorbidities that might make it worthwhile, and it's very expensive. So enough.
Sure. Wish I could speak on it, but again, I just don't have any experience with it. But thank you for sharing that with us.
Anyone else have any other questions? We are going to have another lecture with Dr. Davis on Thursday, June 6th, and this one will cover medication-assisted treatment for alcohol use disorder. So please do join us if you haven't already signed up for that lecture. And if we don't have any other questions, then I think I will just wish you all a good night and thank you so much for joining us. And Dr. Davis, thank you so much for a wonderful presentation.
Thank
We
you
look
for
forward
having
to
me.
seeing you again on June 6th.
See you
Thank you so
then.
much.
Have a great
Thank
night,
you.
everyone. Thank you so much.